My name is Anissa Mitchell with PMD Alliance. Today, we are going to be discussing botulinum toxins, what they're used for in movement disorders, how they work, what symptoms they address. And with us to have this conversation is Dr. Yasar Torres-Yaghi. He's with MedStar Georgetown University Hospital in Washington, D.C., and he's a movement disorder specialist. He specializes in movement disorders, including Parkinson's disease. He also treats Lewy body dementia, progressive supranuclear palsy, multiple system atrophy, frontotemporal lobe dementia, and probably many, many other ones that we didn't list. But we're so excited to have Dr. Torres-Yaghi with us today. And just so you guys know, there aren't any slides today. This is going to be a conversation style program. He's going to really delve into this topic and help us understand the use of botulinum toxins. And so welcome, Dr. Torres-Yaghi.
Thank you so much for that warm and wonderful introduction, Anissa. Hi, everybody. Thank you for being here with us today to talk about the wonderful indications for incobotulinum toxin A, which is also known as Diomin. It's a nice tool that we utilize in our movement disorders clinics all around the country and the world to be able to improve our patients' quality of life for all of the FDA-approved indications. We're going to stay on discussion on label based on the FDA indications for the utility of that medicine for all of these indications.
Fantastic. So I want to first kind of start off with maybe giving everyone an overview of what botulinum toxin is and how they work.
Absolutely. So how many of you have heard about even the idea of using botulinum toxin injections within a movement disorders clinic? Anybody not heard? It looks like I'm seeing some no's, some hands up. When I was fellowship trained between 2015 to 2017, and I always tell my patients that half of my training was in fact on how to use botulinum toxin injections and utilizing botulinum toxin injections to help our patients with the many things that can happen in Parkinson's disease can be helpful. For example, we can think about all of our patients may at some point in the progression of their condition might need a form of botulinum toxin. So our patients within the movement disorder centers really do benefit from these injections. In fact, about one full day of mine is focused around having our patients on the schedule for botulinum toxin injection for a host of different indications. But all of my patients, what they have in common is that they have Parkinson's disease, but they might be manifesting some symptoms that could use botulinum toxin. The reason why botulinum toxin injections are helpful is because, so botulinum toxins, what they do is they cleave vesicular proteins within the nerves. We know that acetylcholine is the chemical that's very necessary between the nerve and the muscle, or between the nerve and an organ system being even the parotid and submandibular glands that are supposed to produce saliva. There are nerves that use acetylcholine at the end of it to tell the parotid and submandibular glands to release saliva. That's how salivation occurs, right? And as an example, when we would use botulinum toxin injections, the idea there is that what the medicine does is it cleaves the proteins that create a vesicle, which is basically a sphere around the chemical, and it stops the acetylcholine from being released from the nerve, and the organ then doesn't feel, or the parotid gland doesn't feel the acetylcholine because there's less acetylcholine leaving the nerve and triggering the functional outcome of the parotid and submandibular gland. So what you're doing in that case is you're reducing the outflow of acetylcholine from the nerves. And in doing so, you're reducing the function of whatever target it is. So for example, if it's a muscle in the face, When you do injections of botulinum toxin, what you're doing is you're slowing or lessening the release of acetylcholine from the nerve. Acetylcholine is necessary to trigger muscle contraction. So it's actually slowing down or lessening muscle contraction, and that's why we can use it for other indications like blepharospasm, which is an overactive musculature around the eyes, or for dystonia, specifically cervical dystonia, the high contraction of the neck muscles, which also happen in Parkinson's. But the overview of how it works is based on the fact that it cleaves those vesicles, the proteins that are docked on the vesicles, so that acetylcholine is not released at as high of a level, and therefore what it does is it either reduces muscle contraction, or it might reduce the functional outcome of acetylcholine on the parotid and submandibular glands, and it might lessen salivation or sialorrhea.
So I know you've sort of mentioned a couple of the different symptoms that botulinum toxin might be used for, and there's been a couple of comments in the chat about this dystonia. So can you talk maybe first a little bit about what is dystonia and how common it is in Parkinson's?
So yeah, generally speaking, when speaking about Parkinson's disease and dystonia, it's not an uncommon symptom of Parkinson's. Remember, this dystonia can happen anywhere in the body, right? It can happen in the face, in the neck. It can be regional, or it can be focal. What we used to call an organic writer's cramp could be considered a dystonia. You know, people that over time continue to write, when we used to write with pens and pencils and not typing, we might need to change that diagnosis, you know, maybe a typer's dystonia. We even have musicians that have musician dystonia. We may have flutists that their lips may purse like this because they're used to using their lips. We may have people with bruxism, which is tightening of the jaw muscles, which, you know, oftentimes causes temporal mandibular joint stress and strain. We may have people with cervical dystonia or limb dystonia. And what dystonia, the definition of dystonia is, in fact, is it's the co-contraction of an agonist and an antagonist muscle. So when I'm teaching the medical students and the residents of what that actually means, a lot of people know the bicep and the tricep, right? The bicep and the tricep do opposite things. The bicep helps, I'm sorry here because I have my background, but it helps flex your elbow, right? That's what the bicep does. What the tricep does is helps extend at the elbow. So those two muscles do opposite things, flexion and extension. What dystonia, in fact, is, and the way to think about it is, it's stiffening or tightening or contraction of muscles that do opposite things. So you could think about it as the bicep and the tricep. Both of those muscles are overactive because of the Parkinson's disease, as an example. Or it might happen here in the neck. So those muscles that do separate things, that move the neck in opposite directions, they're both over-contracted. So botulinum toxin injections may help to reduce the stiffness or the contraction of those muscles, and therefore they would reduce the motion or the position in which dystonia keeps your head, for example. So dystonia can also be called torticollis. Torticollis means a tilted neck. And so it's not uncommon for patients of ours with cervical dystonia to have that agonist and antagonist muscle contracting. And what that leads to is a conformation of either the head, the neck, or any other part of the body that gets stuck in a certain conformation. And we may be able to use botulinum toxin in a scientific way to help release those muscles, reduce the contraction of those muscles. And the ultimate outcome is, for example, rather than have the head tilted, you might be able to more easily straighten your head. You may be able to easily more lift up your head in certain cases. Or in some people, they have what's called a lateral collis. Their head is tilted to one side, so sometimes injecting the muscles that are causing that head tilt helps our patients keep their head straight so that it's easier to turn, it's easier to walk, it's easier to see things. So the functional impact of the injections thinking about them that way really help understand why we even utilize botulinum toxin injections.
So is cervical dystonia one of the most common forms of dystonia in Parkinson's?
So it's a very good question. Cervical dystonia can be seen with or without Parkinson's. Again, it's not uncommon that a patient of ours with Parkinson's disease also have cervical dystonia. In fact, most of our patients that end up in our clinic and getting injections are our own patients. In fact, understanding the prevalence of cervical dystonia within the Parkinson's community can be very, very helpful, because if you understand that cervical dystonia, in fact, could be a symptom of Parkinson's disease. It's been reported that some form of dystonia may affect our patients in about at least a third of patients throughout the natural progression of their disease. In fact, cervical dystonia itself is also not an uncommon presentation of dystonia. So all of our patients that are seen in our clinic, in fact, are constantly being screened. Our Parkinson's patients are constantly being screened, at least by us, with movement disorders training, to be able to detect cervical dystonia as it occurs.
And you know, having cervical dystonia sounds to me like it would be very painful. But outside of that, like, what are some of the impacts on, you kind of mentioned it, but could you expand a little bit about the impact of having cervical dystonia on certain activities of daily living, like their ability to, you know, complete self-care, feed and see, and all those things that you kind of briefly mentioned?
Yeah, so imagine our patients with Parkinson's. We're already suffering from mobility issues, right? And if you can imagine a patient that already is having difficulty straightening their torso, right? So having that straightening of the torso to kind of sit up like this, it's not easy to do already, because our upper back also and our abdominal muscles cause what's called camptocormia, right? So that kind of stooping of posture could have something to do with abdominal muscle strengthening and contraction that pulls us forward. Now imagine if we then superimpose the idea that we're in fact having cervical dystonia of the neck. That cervical dystonia then becomes even more important to detect, because oftentimes the cervical dystonia will have our head and face tilted downwards and forwards, thereby making it even harder, especially if we have stooped posture, to look forward. So I really think it's an important point that you have to understand that the functional impact of our disorders understanding that can go a very long way, because cervical dystonia can impact our ability to see. It can impact our ability to walk. It can impact our ability to turn our heads. If your head is tilted forward, it can impair your balance, and it can affect your center of gravity. So there are so many things that have to do with cervical dystonia, not just head tilt itself, right? People may also notice more drooling because their head is tilted forward, right? Which has its own potential indication of injection. So cervical dystonia, in terms of its functional impact, can play a major role. Anissa, you said it right. You know, you can imagine how much pain is involved also with people that have cervical dystonia. You know, that's another under-recognized part of all of this, is the idea that pain and stiffness occurs. Pain and stiffness can occur very regularly in our patient population, and they happen concurrently. And that means that the best way to kind of focus our attention is to first understand whether or not cervical dystonia exists, and then determine whether or not pain exists in conjunction with cervical dystonia. We call cervical dystonia what we see with the head and neck, and we look for muscle contraction or hypertrophy, which is even more strengthening of those muscles, where you actually see, rather than the opposite of atrophy, those muscles are strong and big. So we look for atrophy. We'll look for what's called anterocollis, with the head pulling forward. We'll look for a head tilt, Sometimes patients can get what's called retrocollis. Their head is tilted back. And we look at the musculature, specifically of the sternocleidomastoid, the trapezius muscles. We'll look at the splenius, the semispinalis, levators, the scalene muscles. These are all things that we are looking at when diagnosing cervical dystonia. However, if pain is involved, we then call that cervicalgia. Not only is there cervical dystonia, but that there's also pain in the neck associated with the dystonia.
And I'm curious, with the head tilt or even the retropulsion or retro tilt, whatever you call it, is there any issue or concerns in regards to swallowing, eating and swallowing, chewing and swallowing?
You know, it's a very good question. You know, well, one thing that you have to look out for all of our patients is swallowing. So we do say sometimes, you know, depending on the way the head is tilted, it may or may not affect the way people are swallowing, right? So understanding that in some cases, dystonia, in fact, can affect the esophagus and the muscles of the esophagus. So we may have increased contraction of those muscles. So there may be some relationship between stiffness or tightness of muscles of the neck and stiffness or tightness of muscles around the esophagus. Now, we cannot target the muscles around the esophagus the way we do injections in our clinic, but we do inject the muscles of the neck. Another important aspect to this is understanding, in fact, that we always need to monitor swallowing, right? That's something that just in our patient population that we look for. Or for people that may have stiffness of the jaw muscles, you know, that could affect our ability to open our mouth and chew, etc.
So I'm curious about, we've had a couple of questions in the chat about other forms of dystonia. So can you maybe touch on some other areas of the body that might experience dystonia and Parkinson's?
Yeah, generally speaking, for patients, something just that we look out for, and it depends on each patient, right? Everyone has a different propensity for different things, of course, but when we think about it, we're always on the lookout, not just for neck dystonia, cervical dystonia, but dystonia of any part of the body, specifically limbs, right? Arms and legs can have dystonia. Your trunk can experience dystonia. Your facial muscles can experience dystonia, which is what blepharospasm is, right? Where you're overactive, and it might look like blinking like this, but it's really an overactivation of the orbicularis oculi muscles, which are the muscles that close your eyes. So understanding that is helpful, but also understanding that we can have dystonia of the hand, of the forearm, all the way up to the distal portion closer to the shoulder, and you can have focal limb dystonia. We can have focal limb dystonia, which is dystonia of either the upper extremities or the lower extremities. The foot, the calf, the thigh can be affected. So all of these things can happen in Parkinson's, and we call that limb dystonia. There's also an entity, which is an interesting entity. It's called a focal task specific dystonia. So focal task specific dystonias are just a way that we call a writer's cramp, right? Or if, which is focal, meaning it's in a specific smaller region of the body like the hand, and it's task specific. So it's task specific to writing. That's the task. It's specific to writing. And it's a dystonia because we know we get a pull, for example, of the hand. Musicians can also get it, as I mentioned. Sometimes they'll have it in their hands. Pianists can have it in their fingertips, in their fingers. Flutists will have it. It's called embouchure dystonia of the lips, and so on. And that's kind of how we think about things. Runners that run a lot can, in fact, have a runner's foot dystonia. And it happens, we think, because of overuse of the muscles and kind of resetting that circuitry in the brain to kind of overuse, but then you kind of create that low threshold to contract.
We had an interesting question. How does dystonia differ from a cramp?
Very good question. So dystonia, unless it's a focal task-specific dystonia, dystonia itself is consistent, it's constant. Unless it's task-specific, then it might be episodic based on the task you're doing. Cramping can happen at any moment, and it's not task-specific. It's specific to a position, or sometimes, like if you're laying in bed at night, you might get cramps, and cramps do tend to be painful and episodic. So the painfulness and the episodicness nature of cramping kind of distinguishes cramping from a more consistent dystonia, or a task-specific dystonia that occurs specifically with the same task.
So you mentioned it before, and I don't know that everyone is familiar with the term of blepharospasm. So I wondered if you could talk a little bit about what exactly that is. You started to touch on it, and what causes it.
Yeah, you bet. So you can have what's called isolated blepharospasm. So in the absence of Parkinson's disease, blepharospasm can exist. In fact, dystonia can be its own diagnosis in the absence of Parkinson's. There are patients that have a separate diagnosis of generalized dystonia, regional dystonia, or more focal dystonia. Dystonia, as we said, means that it's a contraction of muscles that tends to be constantly there. But in blepharospasm's case, what happens is it's episodic in a way, but it's really the overactivity and the contraction of the muscles around the eye that can happen as its specific entity of just blepharospasm, or can be part of a greater syndrome of blepharospasm, oromandibular, which is more lower face, and cervical dystonia. We do see that in certain cases of dystonia. We call dystonia, it's a hyperkinetic condition. There's too much contraction of those muscles. So dystonia, the idea there is, if we have someone with blepharospasm can have a functional impact, of course. It can affect your vision. It can make it so that it's hard to see forward. Some patients have constant contraction of their eyelid muscles. It's very hard for them to open their eyes. And so we utilize botulinum toxin injections, and we may inject the muscles around on the upper and lateral and lower eyelid for patients, or sometimes we'll even inject around the forehead and the middle portion of the procerus and the glabellar lines and the muscles here, and then around the upper face as well. There are muscles that can contract with blepharospasm that we might target.
Does blepharospasm cause any other issues like sensitivity to light or any irritation of the eye?
Well, you know, it's a great question. Sometimes patients with blepharospasm have triggers. And so sensitivity to light can happen around, meaning that, if light hits the eye, sometimes it can trigger the eyelids to close. And so that sensitivity to light, it's not so much sensitivity to the eye itself, but it causes, and it may worsen the blepharospasm. Some patients might report that wearing sunglasses helps reduce the blepharospasms, or less straining of the eyes with overuse can sometimes reduce blepharospasm. But in that way, Anissa, yes, absolutely, that sensitivity to light is really that it can trigger the blepharospasm to and make it happen.
So I had worked with a person with Parkinson's and a care partner a few years ago, and this kind of gets into some of that quality of life, relational aspects of having something like that. First of all, they didn't know that that was what was going on, but the care partner was so frustrated because her husband was sleeping all the time, and he actually wasn't asleep. His just eyes were closed, and then he was frustrated because she was always nagging him see if he was awake. And you know, it seems to me like there could be some potential, I don't know, issues with people understanding that, having an impact, you know, their quality of life, or even some stigma associated with that. Would you say that that's a possibility or the case in your experience?
You know, that You're right. Your story, oftentimes there's commonalities, right, between different stories. And so you bet, you can actually have that sort of unfortunate negative impact on relationships. It can be hard sometimes for people to even understand that blepharospasm is and can be part of Parkinson's, as an example. And it might seem like someone's sleeping, or someone's not interested, or maybe not focused on something, somnolent, or that it might take more effort for a patient to open their eyes. And that can be difficult. It's important, though, to distinguish between, there are some patients that, in fact, have difficulty opening their eyes. And that's more of a central function of the brain. It's more of a parietal function to keep your eyes open. That's different than the contraction of the muscles. Some people just have trouble. They need more help and more energy involved with actually opening their eyes. So it's important that if anyone's having trouble with opening their eyes, to distinguish between a difficulty in opening the eyes versus an over contraction of those muscles, which is why a dedicated evaluation for blepharospasm is very, very important.
Absolutely. The other questions we're getting, and I know we're planning on talking about it, is sialorrhea, drooling. And I know that's a big quality of life issue, but it's more than just that. Can you talk a little bit about drooling in general, and then how botulinum toxin, and you did sort of touch on it, but get into a little bit more about the treatment of that with botulinum toxin?
Absolutely. I kind of briefly mentioned all the different kind of things that we can utilize botulinum toxin for. We talked about cervical dystonia, which is important, blepharospasm also, which is important, but absolutely we can't forget sialorrhea. We call it sialorrhea, so which means over salivation or salivation, which can lead to drooling. And it is a problem that we tend to run into in Parkinson's disease. It's been reported that up to 2/3 to maybe 70% of people with Parkinson's may experience drooling or sialorrhea throughout the progression of their condition. So it's an important factor here, because there's two parts to drooling. Understanding the mechanism of drooling. Sometimes in Parkinson's disease, it may be over salivation. You might be producing too much saliva, or it could be that you're removing too little saliva. Remember, our swallowing reflex and our swallowing capacity sometimes we see a decreased frequency of swallowing in Parkinson's disease. So we may pool more saliva, and we may in fact even have a tad bit of cervical dystonia that's pushing our neck forward, making it even easier for drooling to occur. And so, or the saliva actually coming down and either making our clothes wet, or making us need a constant handkerchief or tissue paper and use it. And that can have huge social impact, can lead to embarrassment, or can lead to just difficulty in doing things like swallowing. Again, also aspiration pneumonia, which is something that we have to avoid as we get older in general. Aspiration pneumonia could be made worse with drooling and that pooling of saliva. So it's important to address the fact that our medicines that we use, the botulinum toxin injections that we utilize, are really not only helping reduce saliva, but then the impact and the other things that happen as a complication of the over-salivation or the drooling.
And it really is a quality of life issue. I mean, you mentioned several, just socially being comfortable, how you feel about yourself, your clothes getting wet, but skin breakdown is a real possibility as well, correct? If it's not treated?
Yes, absolutely. If we keep irritating the skin because of saliva, that can lead to certain things, including skin breakdown, infection, etc. So kind of focusing on that is important, and recognizing, if it's something that is happening, there's different ways to address it. There are oral therapies that can be used, and there's even patches that can be used to help reduce drooling. the problem with those therapies is that they may, in fact, they have side effects. So, you know, we think about the adverse effects of everything, right? Injections carry their own adverse event profile that we watch out for, and we make sure that we know risks and benefits of. But the medicines that we can utilize, in fact, they tend to be what are called anticholinergics. Remember, they block acetylcholine, and they may block acetylcholine receptors. And in doing that, oftentimes, the biggest thing we look out for, cognition is very much driven by acetylcholine. So our memory, our cognitive function, our attention, our executive function are driven by that chemical acetylcholine. So medicines that are given may block acetylcholine, and in doing so, we have to be careful because they can cause confusion in our patient population. So we tend to consider avoiding them whenever possible and considering botulinum toxin injections instead.
All right, so we're getting questions, several now, about side effects of toxin injections. Can you talk about those a little bit?
Of course, you know, everything carries risks, right? An oral medicine carries risks. The different dosing, going up on a medicine that might not cause a side effect at low doses, the higher the dose, then the higher the risk of side effect. The side effects that we consider, we need to think about in patients that we use botulinum toxin for. Number one, there are procedural things to look out for, right? So it's not just the effect of the botulinum toxin, but what can happen with the injections. So the injections can be done in different ways. Injections can be done using EMG, which is essentially a wire that connects to a computer that's connected to a hollow needle. And that allows for us to be able to read the muscle waves. So we may be connected to this computer, and the needle itself essentially is sensing electrical activity of the muscle. So we use the syringe that's filled with botulinum toxin, and we connect it to that EMG computer, which has a needle attached to it by a wire. And as we squeeze the syringe, the medicine comes out through the hollow needle and into the muscle. But utilizing EMG guidance helps us reduce the risk of side effects because it allows us to know, looking at the muscle activity, that we're in fact in the muscle that we are trying to target, number one. Number two, sometimes we may use ultrasound, in fact. So there are certain injections, for example, for sialorrhea, that we may use ultrasound to make sure that we're entering the parotid and submandibular glands, given that the musculature and the anatomy and everything, the glands, you know, can be different for everybody, and then in different parts of the face. But also there's so many structures in the face that are close to each other. So sometimes utilizing imaging guidance helps reduce the risk of side effects. So doing things in a formal method and preparing ourselves to be able to visualize and hear muscle activity helps us reduce risk of side effects. That said, procedural side effects can include bleeding, bruising, and then other things, including pain, right? Injections can be painful, right? So what we do is we try to use very, very small needles so that we don't feel a lot of that pain. So because the needles are smaller, it tends to help reduce pain and then reduce the risk of hitting other structures. The other things that can happen, let's go by indication. So if you go around the eyelids, what might happen is sometimes, because what are we doing with botulinum toxin? For blepharospasm around the eyes, sometimes it can spread and it can move to the muscle that actually opens your eye. So sometimes we can have what's called ptosis. The muscle actually, might get a little bit of a closure of that eyelid. If that can happen, that's called ptosis. The other thing that can happen, for example, with injections of the parotid glands and the submandibular gland, we're trying to fix the drooling, but sometimes we can get the opposite effect. Sometimes we can get dry mouth. And if dry mouth occurs, then that can carry its own risk of problems, right? Over salivation can affect your dentition. but so can drying, right? Over drying can also affect your dentition, your teeth, so infection and cavities can be caused by both over salivation or over drying. There's a way to fix the over drying if it occurs. Sometimes we'll just have patients use an over-the-counter treatment. There are certain mouthwashes or rinses that, in fact, if we get over drying, that can help promote saliva. But if that were to occur, we'd have to consider reducing maybe the dose of injections. Another point is when we do our neck injections, it's important to recognize that sometimes we can have over weakening of the muscles. In fact, sometimes the muscles that hold your head up we can have dropping of the neck. The other thing that can happen is if the medicine spreads, sometimes it can affect our ability to swallow. So those are the things we look out for. So how do we mitigate those risks? We use EMG guidance, we use ultrasound, and we start low. We start with a low dose and we set our expectations because it's a journey. Botulinum toxin injections, because we want to make sure that we don't get any side effects, we start at a low dose, and then 3 months later, because you do the injections every 3 months, give or take, and we might increase the dose slightly, and then third dose, we might increase the dose slightly. So we're moving up slowly the dosing regimen to make sure that we follow that saying with all of our medicine, start low and go slow. We always think about gently introducing medicine and botulinum toxin into our body.
Well, and you answered some questions because there were some questions about how much do you give and then the frequency. Is there a difference in frequency regarding where it's being injected?
Generally speaking, they're about 90-day intervals. So that's how we do it. So regardless of location.
And is there a length of time limit that people can have it? Is there like you shouldn't have it after 3 years or 5 years or anything like that?
Well, once we get to the third or fourth set of injections, that's kind of how we set our expectations, right? It takes about 3-4 sets to really find that sweet spot of dosing and knowing that, how it is that what tends to happen is the botulinum toxin can take anywhere between 5 to 14 days to start feeling the effect of it, right? It takes time to have the effect after the injection. And so we tend to see a duration of benefit anywhere between 5 to 14 days after the injection, all the way through 11 to 12 weeks, right? So our goal is to hit that stride so that we have long enough benefit to time perfectly for our next set of injections. So that's what we tend to do. There also may be a cumulative effect over time, but there doesn't tend to be, a certain amount of time that people might do it. I mean, we have patients that have been doing this for many, many, many years, and that's how they get relief of their symptoms. What happens is after the 3 months or the 12 weeks, the medicine effect will wear off, and you might see a return of those symptoms. We know in Parkinson's disease about daily wearing off, of course, right? But these are 3-month wearing off intervals. So we always ask, when did the injections take effect? When did you feel the effect? How many days after the injection? How long of duration of benefit did you get? And are you having any side effects? Those helps us decide, because everything can be fine-tuned and adjusted to improve safety, but also to improve efficacy and the benefit from these injections.
And these are used in other movement disorders, correct? Like you may utilize these in like a PSP or MSA potentially if they have dystonia, cervical dystonia.
Absolutely. We may use, in patients with Parkinsonism, all forms, atypical Parkinsonisms like multiple system atrophy, progressive supranuclear palsy. Absolutely, we can use botulinum toxin injection. People with different forms of dementia, Lewy body dementia, may also suffer from similar symptoms, and so we use them in many, many cases, and we use them in non movement disorders and memory disorders fields as well. We use them in the neuromuscular fields, etc. So it's not uncommon for us to use this for people that have stiffness, like post-stroke spasticity, for example. After a stroke, botulinum toxin injections can be helpful.
And I know that you did touch on this, but we did have a question, if maybe you could go back, of whether these injections could potentially worsen swallowing issues.
Yeah, it's one of the things we have to look out for, right? Especially with our neck injections, we have to make sure, that we're utilizing the proper methods. And oftentimes, we have to weigh risks and benefits. So in people that we have to be careful with difficulty swallowing, we call that dysphagia. It's a risk that we have to look out for. Again, how do we mitigate that risk? We use low doses. We start low, we go slow. And there's ways also to avoid the higher risk muscles sometimes. So you may want to omit the higher risk muscles of the anterior neck if we're overly concerned, rightfully so, for difficulty swallowing. So, you can inject in the other portions of the neck that may have less risk of a side effect of difficulty swallowing.
And I'm curious, if someone is not seeing a movement disorder specialist, can they get an injection from neurology? Is it just movement disorders or neuromuscular that does these injections?
A great question. The training of injectors is part of many movement disorders programs. Also physiatrists, which are called physical medicine and rehabilitation doctors, are trained to be able to utilize botulinum toxin injections. There are plenty of neurologists also that are not movement disorders trained, that have been trained to utilize botulinum toxin injections. But generally speaking, it's neurologists and physical medicine and rehabilitation doctors, physiatrists, that have been formally trained on how to utilize botulinum toxin injections. In my fellowship program, it was a 2-year fellowship, and out of our week, I would say about 30% of our week was botulinum toxin injections. In addition, we would see patients in our clinic, but we would also do botulinum toxin injections. And so part of the movement disorders training truly is really learning how to be a subspecialist in botulinum toxin injections. And it allows for us to really complement our practice to utilize these procedures to improve our patients' quality of life with Parkinson's. The Parkinson's community suffers from these 3 things: blepharospasm, sialorrhea, and cervical dystonia. And as I said earlier, it's not an uncommon thing for me to say, well, I'm noticing, despite our treatment, that you're still having trouble with your neck. You in fact have cervical dystonia, and we'll talk about risks and benefits. And we identify our patients within our own practice, and we're able to teach them, hey, there's something more that can be done to raise your neck up and your head up so that, it's a lot easier for you to walk. It's easier for you to look up, watch TV, read, socialize, talk with your family, etc. Or we can reduce drooling. If we reduce drooling, not only do we get rid of the whole social impact of drooling, but all those other things that I mentioned can improve. And that in and of itself can improve your ability to do things with your mouth, including talk, right? If you don't have to be worried about drooling, it might be easier for you to speak. And then we talked about blepharospasm and the impact that might have just strictly on improving your ability to keep your eyes open. That can improve so many different things indirectly, of course.
Well, absolutely. And, it's such an important tool in their arsenal, right, of treatment. And so I know there's a lot of people that haven't even considered botulinum toxin treatments for a lot of these symptoms. So it's important for us to understand what they treat and how they work. We did have a question in regards to cervical dystonia. This person said, can the side effect of head drop remain if they have a problem that's a side effect from it? Do they resolve, or is that something that's ongoing?
It's a good question. It's predicted that the effect of the botulinum toxin, both good and bad, or unexpected, or not intended, like an adverse event, should last the duration of 12 weeks, right, or the 90 days. So if we were to suffer from a head drop as a result of the injection, then over time things should improve. That's what's expected, because the medicine itself won't be active and won't be creating that reduction of acetylcholine leaving the nerves. So once you're able to kind of see the effect of the medicine wane, you'll have that acetylcholine come back and create that contraction of the neck muscles again.
And then we had a question, you were talking about, you start low and you go slow and you build. So this person said that their husband had an injection by their movement disorder specialist for drooling, but he stoops and lowers his head, and she wants to know, should they try another treatment at the 3-month mark if it didn't really help a lot for the first injection?
Yeah, everybody's case is completely, unique, but, what I tend to tell patients in general is the kind of the same idea of this treatment journey that we think about with our oral meds. It's always a journey. There's a botulinum toxin injection journey. It's a journey, and you start low and go slow and set expectations. That's a big one, to make sure that when our patients sign up for this, they know what they're signing up for, right? They know that this isn't a one injection. We may be able to, with low doses, the way we inject initially, we may be able to get rid of the symptoms, and sometimes we're lucky there. But oftentimes I tell patients, persist and consider a multitude of injections. Around 3 or 4 times is what we tell patients, because that allows us to slowly get to the dose. And then we can always fine tune as well. Sometimes we'll omit one injection and we'll say, oh, what's happened? I'm seeing more hypertrophy in another muscle. So we may kind of change the way we inject throughout that treatment journey. We may have patients that have been injected for several years that we may say, you know what, you're developing some stiffness in your other muscles of the upper back, or like the trapezius muscle and your levator. We can target those muscles as well. We might add on those injections. Or we may have patients that have both sialorrhea or drooling and cervical dystonia, and we might inject them for both things. And the condition may evolve, right? And we may have started off with cervical dystonia injections, but several years down the road, patients started drooling. So we might just ask the insurance company to allow for us to increase the dosage so that we have enough to do both indications. So absolutely, I think this is a journey. It takes time, and it takes, in general, several sets of injections before we can really determine whether or not we're getting that effectiveness from the medicine.
Fantastic. That's very helpful. This is an important question. Somebody wants to know if somebody who's had DBS can receive botulinum toxin injection.
Absolutely. Many of our patients with that we inject also have deep brain stimulation. Sure.
Wonderful. And I think we have time for one last question. So I think it's more around like what is dystonia and what could be a tremor. So this person wanted to know if you could comment on effectiveness of injection for a lip tremor. So there's a difference between the two. Can you explain that maybe?
Yeah. Did you say limb tremor, or
lip.
did you say
lip?
Oh, okay. So, you have to think about the different indications. Right now, we have indications for blepharospasm, cervical dystonia, and sialorrhea. Understanding whether or not a tremor exists, it's important to recognize, is it a whole body tremor that's making your lips tremor, or is it a jaw tremor that makes it look like it's a lip tremor? For certain forms of dystonia, for example, for Embouchure's dystonia, which is something else, we tend to see pursing of the lips, not so much a tremor. But these are the things we look out for, absolutely. I think it's important to determine whether or not any one of those three indications exist, and check with the movement disorders team and see if each one of us that's interested in potentially utilizing botulinum toxin might be a candidate or not. You know, we have to make sure, for example, that cervical dystonia in fact does exist. Sometimes you can have head tilt or head forward movement, but it's not cervical dystonia. It could be a multitude of different things. So coming up with the actual diagnosis, I think, is very important before determining whether or not we can move forward with botulinum toxin injection.
Fantastic. And then last, insurance. Does insurance and Medicare cover botulinum toxin?
Yeah, you know, it's hard because it's a timely process. Also, that's a journey, right? Getting the approvals for our indications can be a journey as well. And so we, in fact, in our clinic, we have a whole team that works on botulinum toxin insurance approvals. And so a subspecialist should be able to obtain insurance approval. And anyone that knows about the field and botulinum toxin injections and the indications should be able to get it approved by insurance, especially for those indications.
Awesome. Well, I want to thank you so much for reviewing all of this information. It's such an important conversation to learn about what all of these issues are and then how botulinum toxin can address them. So thank you so much. Thank you everyone for joining us.
I wanted to thank everyone for listening and being interested in this. I advocate for our patients to continue to learn about all the different things that a movement disorders clinical team can offer. You know, simply just hearing about this, it makes me really happy that, you know, there are some people that haven't heard about this, that I was able to educate about what we do and the indications. So, and it's a great job to PMD Alliance for making things like this happen. I think there is a huge unmet need to discuss botulinum toxin injections within our patient population. Thank you so much.
I agree, and you're getting kudos. So I'm going to invite everybody to join in our tradition of the wave of gratitude. We thank you so much, Dr. Torres-Yaghi. Thank you, everyone, for joining us.
My pleasure.
All right,
Bye-bye.
have a great day. Bye.